All right, well, I think we should get started, and if this is going to be taped, it can be sent to the rest of the team, when available. How's that sound? Because
Yeah, it's good. People will
now
come and go and that sort of
Right.
thing. So
I
we've got,
watched several of these taped after the fact, and they've been quite helpful.
yeah, well, we'll have an intimate gathering, and you can interrupt if you like. I'm gonna play Oprah on this one, and thank you, Ginger, for setting it up. But since it's a small crowd, we can just be super cash. And I will just sort of lead off by saying that I trained at the Mayo Clinic in 1996 to 1998. I did a research fellowship, and then I did a clinical fellowship. I worked with Frank, and I worked with Doug Pritchard, Mike Rock, and Tom Shives, so four of the tumor surgeons at Mayo at that time. And you know, that was after a residency at Iowa, and it was an exceptional experience, primarily with Frank Stanton. So, I mean, everybody's loyal to their fellowship. That's what's fun about this field. We all enjoy the mentors that taught us, but and I'm no exception. It was the teamwork at Mayo and the just mind-boggling focus on the patient that I've never seen at any institution since. I still think it's the best place for patient care that I've ever known. So anyway, Frank's one of my greatest mentors, if not my greatest mentor. His pictures on a big frame picture on my wall in the office give me a little inspiration when I've got those hard pelvis cases. He's been a mentor, a sponsor, a leader, a teacher for me, and and then the greatest thing about these kind of relationships, we became friends, and so now we've been friends for a long time. So it's super fun to be able to have a chit chat with him tonight. So anyway, since you don't know Frank very well, we're going to start at the beginning, and I'm going to ask him some questions, and Frank, you can ad lib as much as you want. So I wanted you to give him a little background. Where you're from? Small town boy.
All right, Kristy. Thanks for putting this together. I think it's a great initiative, actually, for the society. Well, I had a serendipitous journey to Mayo. I grew up in a small coal mining town in Nova Scotia, and our capital city is Halifax. So I did study science there, and went on to study medicine and did an internship year there, and then, as was the ivory tower approach in those days, I came to Mayo to study medicine. So it was an interesting year, but the more I saw the exciting developments in orthopedics at that time was just beginning. So I said, okay. So I went over to the operating room to visit with who was our chair then, Mark Coventry.
Hey, wait a minute. I'm gonna have to interrupt you there, Frank, because you jumped ahead like 20 years. So I want to go back.
No, I'm still there.
You're not.
I'm an
I still
internal
want to be
medicine
I want to
resident.
be in Nova Scotia still.
Oh, okay. Well, you've been to Nova Scotia.
Well, I know I've been to Nova Scotia, but I'm just saying, like small town, wasn't your dad a coal miner or something?
Well, it's a coal mining town. Yeah, my dad was a coal mine. I worked in the coal mines 1 year, and then I figured I had to get out, and so found another job the next summer. So you learn from experience, or you should anyway.
Well, I know you're good at science, good at everything, but that is not what you were doing in Canada. So let's spend a little time on what you were actually doing in Canada before you made it to the ivory tower. What were you doing in your spare time in Canada?
Well, the
What does
question.
every kid in Canada do?
I don't know what you're looking for, Kristy.
What does every boy in Canada do?
Okay, well, so anyway, I got to Mayo, and from my early background, every boy grows up in Canada wants to be a hockey player, right? That's the noblest path you can take. So that was my dream too, and I had a lot of success early in my career. And so the NHL scouts came to my door and offered me a career path in that. And my mom said, "No way, son. If you're going to play hockey, you're going to do it at university." So off I went to university, and like I said, I studied science there, but I'm sure I majored in hockey. And hockey's always been a big part of my life over the decades. Even in my early career, we continued to play senior hockey, and And at least getting worse so you could be a star, and led it to the beer leagues we call old timers, or former
Well,
greats, some call it. So anyway, hockey's always been a big part of my life.
well, I've spent a lot of time with Frank, and so I've seen the scrapbooks, and he's underplaying the sort of his his fame in Nova Scotia, and the idea that the scouts came to his house is not a lie. So you really had a fork in the road there. You could have done something different, even after college, I'm sure. So, and I will say that Frank, hard as this is to picture, Ginger, he did have me out on a pond during my fellowship. He put some skates on me, gave me a hockey stick, and taught me how to do a slap shot. That was part of the training.
You were very good. You had promised. You're a good athlete, so it would have came to you. And then we made you the goalie, I think.
I didn't do well at all, as a matter of fact, but I was impressed that you were still skating around,
Okay.
looking like a hockey player. So, okay, sorry about that. I just wanted to sort of, it's a little bit of a different background than most people have when they're heading into the field. So, yeah, go back to your Mayo story, but maybe talk a little bit about teamwork and how that evolved, probably because of your background on the team.
So anyway, Mark Coventry got me into our program the following year, and I was never sorry with all the advances that were going on. So yeah, teamwork was important, and I think it was clear I wasn't going to reach the top of the hockey world, but a lot of orthopedic surgeons have a sports background, and they learn lessons from their coaches and their trainers, which have an influence on their surgical career. Particularly, you need a strong team, diverse skills to meet the challenges, particularly us in tumor work. So that can seem like old hat in today's practice of surgical subspecialization. But in those early years, when we adapted it, was a fairly novel concept. It's always been a joy for me to work with such a fine group of different disciplines at Mayo to establish this and improve the outlook for our patients.
And again, just to amplify that, when I was a fellow, and Frank was in, reasonably far into his career at that point, but he would put on these cases. He would see a patient, and he would put the case on 2 days later, and it would require 6 or 7 teams, as we know, the colorectal team, and the plastics team, the vascular team, and all these other teams, and it didn't matter if everybody else already had a full day. Everybody at Mayo jumps in and is part of the team for these big cases. And since they do it so often, and since the volume of really big, especially the pelvic cases, everybody has a role, and it's not like learning it the first time. It just, everybody sort of jumps right into their role. And the thing that I noticed is the senior surgeons would be mentoring the more junior surgeons on the faculty there, and it would just continue to go. Frank was always the same for like a zillion years, but there would be all these different colorectal surgeons, vascular surgeons, all the different subspecialties. So it's pretty amazing, Frank, to watch that, right? I mean, watch people sort of start out and then get to be really exceptional.
Yeah, exactly. I can't add to what you said. It's just the evolution at Mayo, and it's been adapted around the world now. I know all of our centers have this team approach, so we can work together and accomplish things that we do in tumor work.
So when you started your career and you were at Mayo with Coventry and Jack Ivans, what was MS oncology like? Like what were people doing then in the OR? What kind of cases? What was the status of chemotherapy?
When I come on staff in 1970, I worked with Doug Pritchard, and we joined Dr. Ivans to set up the division of muscular oncology. Prior to that, tumors were treated in a rather ad hoc manner by many surgeons, and the results were really pretty dismal. At that time, amputation was the only method of treatment. People died from their cancer primarily. And I remember in those eras, the real emphasis was not on clinical work, it was on clinical pathological correlation, trying to describe new entities. And the people who are most prominent then, you could remember probably 5 people. They were all, when they finished their training in orthopedic and surgery, they did a Hatcher Fellowship in Chicago, and they became pathologists basically. Of course, the most well-known was Bill Enneking, and he undoubtedly is the father of muscular oncology in America, at least. And Bonfilio in Iowa, was he still there when you were there?
He was.
Yeah, Gene Mendel in Buffalo, Rosenberg. So these were giants in that era, but it wasn't a treatment emphasis. It was on pathology. So staging was horrible, and all we had for the first 5 years of my practice was bone scans, plain X-rays, angiograms. So staging wasn't good. You can imagine doing that today. So left a lot to be desired.
Amazing. Yeah. I mean, MRI scans didn't come into the mid 80s, right?
Yeah, there all these advanced and related fields improved, or especially a CT by mid 70s. A decade later, MRI. But I think the biggest advance was developing effective chemotherapy. The first report was in 1982. That was from Roswell Park, showing significant help of osteosarcoma from pulmonary osteosarcoma from adriamycin. So things were advancing. All these advances really stimulated people to start doing limb salvage procedures. And it was quite controversial. But the two big points was Bruce Rugraf did his classic paper. I think that was in the 80s, showing that amputation and limb salvage were comparable. Then there was an NIH consensus conference, which Mayo and many centers presented at, and they labeled limb salvage the standard procedure. So then things took off, and there were a lot of bumps in the road. The MSTS played a big role in the principles. I remember the founding meeting. There were 16 surgeons, went to Boston, and the biggest item discussed was what level do you amputate? That was the biggest discussion. That was 77, because there was great concern about skip lesions in the bone. So many patients had unnecessary disarticulations. So that all began to change. And
Well, who was there? Who was there in 77? Like, can you give us a couple of names of who the gang was back then? The first MSTS meeting.
they're all there. Dempsey
was Mankin there? Mankin and
Dempsey
Springfield?
was Bill Annyking's fellow, and Bill couldn't come, of all people, because he was running his course. So he sent Dempsey. But
was Henry
Mankin,
Mankin there?
of course, Markov and Mance, and Mankin. You go down the list. Doug and I were there, so it was really a fun meeting. But do you know why they call it the Piranha Club for the first couple of years?
No.
That story. Well, the minutes read that there was a vigorous exchange of strongly held opinions in a somewhat adversarial manner. So it was called the Piranha Club for the first 2 years.
I think
And
some
of course,
meetings are still like that.
Not enough.
It's interesting anyway, but
Not enough.
those days it was very competitive.
Well, it's just, I mean, Ginger, can you imagine like having the career that Frank's had, going from no chemo, no CT scans, amputating everything, to doing sort of the most complicated pelvic limb salvage that anyone's ever done. So it's an amazing time period that you've been in, Frank, and sort of how you contributed to it. Tell us about, oh, go ahead, I'm sorry, Ginger.
Well, I was going to ask, seriously, how would you prep in 1970, 71, 72, when you were going in to, you're looking at a huge thigh mass in someone, you had to have had, clinical physical exam skills like we don't even understand today. You're walking in to do a hemipelvectomy or something. How did you approach that?
That's a very good question. And I think the people who were doing it had three-dimensional visualization. You have to be able to visualize it, because this was, like you say, in those areas before cross-sectional imaging, and then CTs, we're working with CTs, so there was a bigger margin of error, and MRIs improved. So it all kind of came together gradually, and we got experience with what we had. I think it's just a matter of developing.
Well,
what was the first limb salvage case you remember doing? So you probably did a lot of amputations. And what was the first case where you remember saying, you know what, we really could carve this tumor out. We could close the skin. We maybe use a plastic surgeon. where was that? Was that still before there were MRI scans? Did you use a CT scan to do that? Like, what first limb salvage case do you remember?
I think it was an evolution, Ginger. It is interesting to look back, but the early ones were when you would resect the distal femur and do reconstruction with the techniques of that era, and then you evolved into later internal hemipelvectomy, and careful planning was so important. We go down to the anatomy lab the night before and knew basically what we had to do. So I think the planning was key. I remember early on, I was doing a case, and Dave Darlene brought one of our guests in the room, and I met Dr. Campanacci for the first time. So he was walking there watching the case, and it was a chondrosarcoma distal femur. And so we cut across the bone, and this runny cartilage ran out all over the wound. And later on, Darlene said, what did he say? He said, well, he said, I would not do it that way. So you learn from experience. And
Dave Darlene was a famous pathologist. So
yeah, he was our bone pathologist.
I will say that when I'd asked Frank the same questions when I was a fellow, and because when you really have no idea until you watch Frank actually do pelvic surgery, because whereas you're doing your first one as a fellow or Paco when you're now an assistant professor, you're in there on your first hemipelvectomy by yourself, and you're like, where is that pudendal nerve, right? I mean, no idea. And Frank used to just lay that thing out, and I could see it, and I was like, I cannot find that thing. But I used to ask him, how did you get this good? Because Frank can do a hemipelvectomy faster than anybody I've ever heard of, and that's because he knows exactly where everything is, exactly. And so he knows where he can go fast and where he has to go slow, and he got that from, as he said, I think he used to call it working with the boys. So he'd go down and do anatomy dissections over and over and over again, like to be excellent, like to have the three-dimensional anatomy vision that none of us are doing, that we don't do that now. We don't have people in the anatomy labs every night doing dissections in the pelvis, or maybe Ginger does.
Well, Julia has been. Julia's working on her state of excellence.
Good.
In the anatomy lab.
It's hard. It's a lot of practice. Anyway, let's go back. We talked about MSTS, Frank. What about ISOL? How did ISOL start?
Well, ISOLs came along by necessity when the limb salvage reconstructive techniques were coming into play. It seemed like every center had their preferred method of reconstruction. In Florida, they liked resection arthrodesis. Henry Mankin championed osteoarticular allograft. And at Mayo, New York, we were pioneering the first generation tumor prosthesis. So the early results were promising, but we had a lot of problems, mechanical, fracture, and so forth. And so Mayo organized the first international workshop in design and application tumor prosthesis. So surgeons were invited to work with material scientists and bioengineers and manufacturers to solve these problems. So that's where it evolved from. And this group kept going. The next meeting, I think, was in Vienna, and it morphed into the ISOLs, which, as you know, is the premier organization to really help advance the science and application of prostheses to their current standards.
Thanks. Tell us a little bit about just, you've seen a lot of generations of fellows. You've trained US based fellows. You've trained a lot of international fellows. How do you make a decision who's going to be trained at the Mayo Clinic back throughout your career? And how did you decide when international guests were going to come? How did that all work out?
Well, I think every center now does. I think that's probably one of the most important contributions us in teaching centers can do, is to train new generation of fellows to advance the science. So we've done a great job with that with our tumor fellowship program. Started in 1972, and we call it the Ivans program. We meet every year with our former fellows is case orientated. So they get a prize for the best cases. So it's pretty competitive. I think the international fellows, it's really fun for them to come, and they go home to their own country and establish top-notch programs to improve tumor care. They train a whole generation of new tumor fellows. So it's influence increases our influence like branches of a tree. So it's really a progressive thing, I think, that we all enjoy.
Yeah, the Ivans Club is still going. That's one of my favorite meetings, and we're going to be in Rochester in October. So all the past fellows at Mayo come back and bring their hardest cases, and have a kind of a safe space to talk about that. Frank still critiques them.
Can I ask about Dr. Ivans?
Yes. What about
I've never known who he was, even
Dr.
though the
Ivans?
society's named after him.
He was broadly trained. He was a war surgeon, came back to Mayo, kind of general surgery background, and he was a fantastic surgeon, and he was a visionary too. Like I say, tumors in those days were kind of helter-skelter, and so he was studying immunology at night and all the things, and so took over, established a new division at Mayo of muscular oncology. You know, those days hand divisions were just starting and all these other things. So it was really a chance to focus on that. And Doug was always research minded. So we had a great team in those days to try to establish new protocols.
One comment on the international, when I was training there, it was just what a benefit for my career to be able to see these folks that would come in from Turkey or from Italy or from Greece or from Pakistan, and be visiting with Frank, and they'd spend part of the time with us, and so it sort of enhanced our experience as well. And those folks are out there. Panis is now president of the Greek Society, so it was a expansion of our world as well. Frank, I'm not going to give too many stories about how tough you were as a fellowship director, but you're pretty tough. And yet you trained a lot of gals as well. You got the diversity award for the academy back in, I don't know when that was, Frank, a few years ago. Talk about sort of just the diversity, not just in gender, but the sort of breadth of different fellows that you've trained and residents that you've trained at Mayo.
Yeah, that was probably one of the most cherished awards that I've received. And it relates to the very diverse practice we have at Mayo. We have people all over the world with different cultural traditions, and making them feel comfortable in the treatment they receive, I think, is part of it. And also just promoting a diversity in our specialty has been a great initiative. But I think as we move further, we got to see more progress in this area. You can see progress now in how many women are in our residency program and fellows. So I think we still got to make progress in that regard.
Agree with that. So I'm going to ask you a couple just questions about you. There's a lot more orthopedic oncologists now than there used to be. So it used to be that, you had to travel a long way to get to a center where there was somebody. And by consequence, the surgeons that were there in your era and in the couple decades after you started were probably quite busy and did a lot of big cases, big pelvic cases, big shoulder girdle, chest wall cases and things. Now there's a lot more tumor surgeons, a lot more people trained, and multiple people in every center. So, do the math. There may be less big, 3D kind of cases per surgeon. So, do you have any thoughts on, I mean, you're quite good at it and you did so many of them. How do you become competent today in doing the really big cases? And what would you say about that to folks that maybe didn't get to do as many in their fellowship as they would have liked to or will like to?
Good question, Chris. I think the principles are the same. Skill in the operating room is based on preparation, as we mentioned, and experience. But many individuals do not realize the intense amount of planning that goes into large cases because it's not always immediately apparent or visible. However, I've always rehearsed large surgeries in my mind, or as we mentioned, anatomy lab during the development years to try to simulate different approaches, potential pitfalls. Unfortunately, these pitfalls do occur. And this experience, both in surgery's triumphs and defeats, can make you a better surgeon. After every major case, I privately reflect on the entire operation and what did and did not go as planned. So I think this mental debrief and private critique after a large operation is very important to grow as a surgeon. This makes the difference between a surgeon with 20 years experience and one with 2 years 10 times over. As the case volume is very hard to estimate, but surgeons doing large pelvic resections should be doing them on a frequent basis. I have found my experience working with other disciplines, colon rectal, GYN, oncology, to be very helpful because they have a different approach which complements and informs our approaches of these difficult cases. So we work as a team to help each other and gain greater experience and capabilities.
Well, I just want to make one point. So when Frank talks about critiquing the case and how it went and the pitfalls, he means critiquing the fellow and the mistakes that the fellow made and their pitfalls. Is that what you meant, Frank?
No,
I
don't
certainly remember
take
that.
it personal, Kristy.
Okay. All right, next question. Okay, it's a little bit related. So, you're super courageous. You tackled frightening cases, but you always had judgment on and patient-centered care. How do you balance what can be done in a particular situation with what should be done as we develop more and more technology to be able to say we can do something? How do you bring that patient piece back to think about it in a more nuanced way?
Chris, that's a very good question. It's such an important but difficult concept. I've always tried to work out with patients their goals before the operation ahead of time. And this can require a very frank discussion as to what we may or may not be able to accomplish. First, do we accept a close margin of spare function? And what function and outcomes can we meaningfully expect with different options? So the goals of a young mother who wishes the best possible chance of survival is often different from an older patient who wants pain relief and as long a life as practical, but doesn't want to become a burden to their families. So as you know, people think it's hard to speak very directly about this, but my experience is that patients and their families want to talk about these subjects. Today, they call this shared decision-making, but it's really an open communication with patients and their families about the opportunities and also limitations of this field and their diseases. So in this way, patients who have selected either radical or conservative approaches are comfortable with their decisions, and we have confidence in the OR as we move forward.
What role, this is gonna be a little edgy, what role does the fact that Mayo surgeons are salaried and not incentive-based play in deciding how aggressive a surgery to do or whether to operate at all?
The key is, I think, the practice at Mayo is never about the money. We're all paid a salary. It's really about putting the best interests of each patient forward every day. And that's why we can assemble such a great team that works down the OR next to us or around the ORs, because they're all paid anyway, and they just arrange their schedule to help. And it's kind of fun to get together with our colleagues and learning from each other.
I would say I actually think it has a big part to do with the Mayo culture, that whole piece that it's salaried and it's not the more you do, the more you make. So I hope they hold on to that for a long time. Here's another, when I was there, you were still sort of the Renaissance guy doing massive tumor surgery, but you were also doing joint reconstruction, revision joints, and sports. So, I mean, first of all, why? You're like one of the greatest tumor surgeons ever. Why did you do that other stuff when you had a lot of cases to do? What benefit was there? What was the drive to do all those different specialties?
I was going to ask you why you were always late for sports clinic. I don't think you like sports clinic,
No.
but anyway, I was fortunate to have a front seat for so many advances in orthopedic surgery over the years. So we now think of these as separate fields. But 40, 50 years ago, it was all orthopedic surgery. We're all striving to bring innovations to our patients. So I always focus on tumor surgery. We saw everybody and tried our best to help them all. So this is what made my career so satisfying. It was the drive to come back fresh every day. The opportunity to see patients improve by what we did. The wide exposure, as you mentioned, also helped us bring advances from one area of orthopedics and others. For instance, you mentioned revision joint surgery. So I'm sure we did more allografts in massive bone loss and revision joint surgery than tumors. So that really advanced both fields.
Yeah, and it's a good point for today too, as people, again, we've got more people being trained. There's not always jobs that are easily available. And I think, having people be able to stay broad, obviously tumor surgery is what we all care about, what we love the most, but not losing some of that training that people had in their residency or maybe got exposed to in a separate fellowship, to be able to have additional areas of expertise, I think is becoming the norm. Frank, could you talk us a little bit about, I think, you're known for the pelvic resections, and then you really had a huge resurgence on the sacral work. Could you talk to us a little bit about the history sort of advances in pelvic surgery, sacral tumors, and maybe throw in how Mayo's worked with 3D printing over this last, decade?
Yeah, I'll start with pelvic tumors because it's really interesting to look back at the history and developments to where we are today and where we're going. These have been very challenging because of the anatomical complexity, difficult getting clear margins. So it's one example, along with the sacrum, why the team is so important. So when I started my practice, patients were managed by external hemipelvectomy. The results were rather dismal. But in the early 70s, there was a lot of interest in developing internal hemipelvectomy techniques. There were several articles come out. They were doing the work in the 70s. Several articles come out early 80s, I think. The first was probably Howard Steele, who was in Philadelphia, had a small series. Bill Enking had a series, a page with big resections and massive shoe lifts. So now internal hemipelvectomy is the standard treatment today. But in those days, it was obvious we had to improve our reconstructive methods to make them more functional. And even when you guys were training, there's a whole host of things we were doing, ranging from massive allografts. Some worked out pretty good, actually. Pseudoarthrosis was common, probably the most common. Arthrodesis. Saddles were easy, so we liked those, but they didn't work very well. And there were some early attempts at pelvic prostheses, which they didn't have the proper technology, so they mostly failed. So Mary O'Connor was around, and she published her classic article looking at 60 patients from Mayo, and she was one of the first to indicate that the best technique should be individualized depending on the needs and requirements of the patient and the extent of resection. And so techniques have evolved. It's interesting that Mary and one of her other proteges, Dr. Sherman, looked at the same group of 60 patients 30 years later, and they found that the results were very durable, actually. 3/4 of patients were still alive and without disease. So that's really a testament that we were doing pretty good in those days. I think our recurrence rate last time Matt Hodak looked up was the same as we were getting then. But of course, better techniques. And of course, today now with improved technology, my colleagues, Pete and Matt, plus pelvic surgeons around the world now, are really utilizing real-time 3D printed implants with accurate 3D printed resection guides. So this is all moving ahead pretty quick.
What about the sacral work?
Yeah, sacral was pretty challenging because the biggest problem was high local control issues. And in the early years, there were some articles come out. Mayo had a classic article with Bruno Fuchs. Memorial had an article. Ruggeri from Rizzoli emphasizing the importance of more radical surgery to predictably achieve clear margins. So the trend then was to do more radical sacrectomies, which could be pretty radical, removing lower lumbar spine, wing of the ilium, to achieve clear margins. And it's very interesting that how the techniques of reconstruction developed, because it was clear that to be able to enable these big resections, you had to have better techniques of reconstruction. Now, we started our program doing some of these resections in the 80s. You probably remember some. And in those days, we didn't know whether to reconstruct or not. I remember the first one we did was 1982. And Stenner and some reports from Sweden suggest maybe you didn't have to reconstruct them. So the first one we did was L5 sacrum. And so we didn't reconstruct him. We kept him down in a foster frame in bed. And when we got him up 6 weeks, sat him in the chair, his spine fell into his pelvis. He got inferior vena cava syndrome. So we had to go back and reconstruct him, delayed with the poor techniques we had at that time. I think all we had was Harrington compression rods and a lot of bone graft. And each decade, the reconstructive techniques improved. I think in the 90s, we were using the Gelson modification, the Lukey technique. But it really wasn't until the 2000s decade that it really started to improve with the rod screw, pedicle screw constructs. And of course, you know, my colleagues took it a step further to enhance the posterior reconstruction by restoring the anterior sacral arch with fibula grafts. So did some studies in our lab to show that provided twice the resistance to failure as posterior construct alone. So I think Pete Rose and Matt Hodek, and when Mike Yazemski was here, enhanced this, probably in a large series of sacral resections more recently, classifying the resections into different groups according to the novel Mayo classification system. So now we can select the best reconstructive method depending on the type of classification of the resection, and we can predict the functional loss for each type as well as the functional outcome. So this is coming a long ways and is progressing with all the newer techniques.
Well, you've had a major role in the progression of those techniques. So good to hear your comments on that. And talk a little bit about patients, Frank. Your call on this. You know, challenging patients, mistakes. How do you manage mistakes? You do big surgery. When you have big surgery, you make big mistakes. You have big complications. How do you keep going for decades and decades and manage that sort of emotional hit when patients have complications? How do you do it?
That's a tough problem for me to answer because we never have complications.
Right.
No, I think there's really two parts about how we manage these. The first is to be open with patients and their families about what happened and what can be done to make it better. Even today, with all the advances and experience we have, surgery has many unknowns and risks. So it's important to be open with colleagues, trainees about mistakes and complications, because people respect an honest surgeon, but not one who tries to hide or excuse the complications that we all experience at times. And the second part is to be very introspective of complications, to learn from them. I've often said that excellence comes from experience, and experience comes from bad outcomes. People sometimes think this is meant to be humorous, and on some level it is, but at its core, a great career in surgery doesn't come from avoiding complications, but comes from learning from them to become a better surgeon for the next patient. But this also lets me recover emotionally. It gives me a purpose in learning from the complication and moving forward in a positive manner.
Right. I'm glad you didn't say that, gin and tonic was the way to get over it.
It helps.
So, tell us a little bit about, and tell the folks on this call a little bit about how you work with guest surgeons. I know we talked about it a little bit before, but maybe your philosophy on being such an ambassador, because Frank has had so many people come from around the world to the Mayo Clinic, and then he is in turn invited to, I don't even know how many countries you've probably been to as a guest to watch how they do things and to learn from them. I sometimes find that, gosh, I feel like I'm really busy and I don't want to take the time to entertain a bunch of people coming in to visit. And you've never had that issue. You've always treated them like family. Tell us a little bit about how that came about.
Well, it's like we talked about a little earlier, but it's kind of a responsibility to spread the word and inspire our residents and foreign fellows to come. So we had a pipeline of different countries. Rizzoli sent all their young fellows here for many years. Capano was with us for 6 months. They didn't know how to operate then because they weren't operating. But when they came and they could scrub in with us in those days, so they saw a big volume and became great surgeons. So in that group, I think of Donati, Ruggieri, basically all of them, different countries. And when you were there, we had Wei Ming. Wei Ming is the head of the biggest hospital in Taipei today. So it really is inspirational to see them when they return to their home country and establish great training programs and pass the word to the next generation. So when these individuals come, we realize that they're leaving their home and their families and loved ones to spend time at Mayo, probably in the winter, to enhance their educational goals. So we treat them like family. They work long, hard hours like everybody else, and they enjoy all the amenities, social activities that program allows, including tossing for who pays, Ginger.
Well, first of all, Frank, it's always winter at the Mayo Clinic, so there's that. But just I have to ask, you've got people coming from all over the world, cultures that have all sorts of different food, and they have to come to Rochester. Like, what do you feed them? What do you have in Rochester? You got like a steak.
Meat and potatoes.
All right.
Corn. Actually, we're doing better now. It's an international city with all the people that come, so you can find almost any type of food there.
Back in the day, they all had to eat the 2-pound steak, at the end of the surgery day. So
we had a wonderful steak restaurant. You're right.
So Frank, you probably at some point in your career you got recruited to other places to build a program. Why did you stay at the Mayo Clinic for all those years? Why'd you stay?
Well, I think the thing that enticed me most was the biggest value was the camaraderie and friendship among our colleagues. There's really no intellectual controversies or challenges. I think each of us is willing to help each other, consult on our cases whenever called on. At Mayo, we have the 3 shields, like most centers, of practice, education, and research. And we're free to pursue our special interests among these 3 shields. To speak in sports terms, they give us the ball and we're allowed to run with it. As well as you'll see this fall when you come back, Rochester has changed dramatically. It is a beautiful small town, big city amenities. It's really, like we said, a pleasure to live in Rochester, at least for 3 seasons.
All right, Frank, I got 2 more questions for you, and then if anybody else has got a question after that. So my next last question is, the field orthopedics sometimes get a little bravado, get a little ego, and I want to know, you've always stayed incredibly humble throughout your career. You're not the guy that's up at the microphone talking about, his amazing series and how good he is, right? tell us about that. Where is that from your family, or you were never up there rushing to the microphone to brag about your expertise? What's your philosophy there?
Yeah, it's a very kind statement, Kristy. In my career, my focus has been on the care of patients and education of our residents, fellows, visiting surgeons, as we discussed. Importantly, I've never felt the focus should be on me as a surgeon. I actually think it'd be wrong to focus on an individual, as everything we have accomplished has been because of our success as a team, not as individuals. So teamwork, as you know, has been the hallmark of our practice, and it's a legacy I hope to pass on to others. So ultimately, there is a limit to the number of things anyone can focus on. And I want the primary focus to be on the patients rather than me as their surgeon.
Thanks for that. And then maybe tell us a little bit about your family. You got some daughters in healthcare. What's going on there?
Well, I've got two grown daughters. I'm very proud of both because, as you mentioned, they're in healthcare. My youngest daughter, Sheridan, is a nurse practitioner at Kaiser in San Francisco, and she's got a cute 11-year-old son that comes to visit me frequently. And my other daughter, Leslie, is a PhD child psychologist at Mayo, and I know she's intellectual, and you and her relate very well. But she has an interest in pediatric pain rehab and management and eating disorders. So Leslie has two children, a 19-year-old daughter, just finished her first year of college at St. Olaf, and she has a research job at Mayo. So this summer, so I'm hoping to get her interested in pursuing a career in medicine. We'll see. And her 16-year-old son is very smart, not a great student. He's an avid baseball player, so we'll see how he does.
Final question. Who's your favorite fellow?
Well, I think you know the answer to that. My favorite fellow is always the current fellow.
Oh,
There we go.
The transformation these fellows make in a short time between an eager but novice individual and skilled surgeon is both amazing and rewarding. The real bonus is we get to do it again every year and follow the great accomplishments of the ones that came before them.
all right. That exhausted my questions for Frank Sim. Anybody got anything else you want to ask the master? Paco.
Hey, Dr. Sim, thanks for the great talk. Just FYI, this is all these clone armies of my name. That's not me. These are current fellows that use my link to join on. One of which is Gavin. So just don't think there's a ballot stuffing going on here on my account. As you probably heard from the banter before your talk, I just started at USC on staff. I finished my fellowship at Boston, and one thing I'm really curious about when I get the opportunity to speak to some of the giants, or as Dr. Gephardt would say, the old people in the field, is what was your mindset in terms of doing things that really not a lot of folks or no one had previously done before? You've been part of some of the real major advances in orthopedics that was obviously at that time unprecedented. At what time did you decide this thing that has not really been done before is ready for a prime time? This is ready to use in patients, or this procedure is ready for at least getting off the ground. And what was your conversation with them as you are consenting them to kind of be the cutting edge of the field with you?
Yeah, that's a good question to contemplate, because we've seen all tremendous advances in orthopedics over the years, and I think it's really looking for better ways to do things, to bring innovation to our field. And you can think of many things that came along that we would test in the lab, and with 3D printing, that's certainly innovation. It's very exciting to see what's going to come along in that field in the next few years, with biological printing, implant manufacture, biological scaffolds. So I think it's a matter of having seeing the problem, looking for better ways to treat it, and innovational development. So I would keep up. You say, well, you came up in an era where there was very fruitful to lots of things had to be done. There's still lots of things today when we look at it. There are many, many avenues to make progress. The oncologists have to find a way to nudge our survival rate up in osteosarcoma. It's been pretty dormant. So I think asking that question shows you an inquisitive mind to develop innovations to help patients.
Any other questions? Ginger?
Yeah, I'm curious. Herb would tell these stories about you running like 3 rooms at a time. And I'm curious as to how you physically, over the years, continued to be able to work at the level you worked at. Not only physically, but as you kind of mentioned a couple of times, emotionally and doing things. But for the stories that Herb tells from your entire career, the level at which you functioned is unfathomable. And I'm just curious as to how you feel like you were able to do that and do it so well at such a high level for so long.
Well, that's very nice. Ginger and Herb and I had some great fun together in the OR. He was a tremendous surgeon and made a lot of developments on his own. But I don't know, it's an individual thing with energy, excitement to what you're doing. I mentioned with watching patients recover and have good results brought us back fresh the next day. I know the residents used to think they liked me playing hockey at night. So whatever time I get done, we'd be on the rink at late hours of the night. And I was very mellow the next day. No hostility. I had to slam people around the boards behind the net. So I don't know. It was a very interesting career, and we had a lot of help doing what we did. So I'm just fortunate to work with such great people.
Ginger, when a few of us came back for Frank's 40th anniversary of the start of his career, we thought that was going to be the retirement. That was not. But we tried to figure out how many cases he's done, and these aren't like carpal tunnels. It's like hemipelvectomy, revision hip, blah, blah, blah. So it was I wrote the number down somewhere. Peter Chung and I tried to figure that out, but it'll never be matched, actually. It'll never be matched ever with the number of cases and the complexity. Amazing.
What do you think the greatest contribution you've made to orthopedic surgery, orthopedic oncology, for the millions of things you've published on and what you've done? What are you most proud of? What do you feel like was the greatest?
I think Ginger, I'm really most proud of looking around and seeing what our former fellows have done. And amazing to see the young fellows go out in the world and develop such talents and skill and make such contributions and be leaders in the field. I think that's what really gave me the greatest satisfaction.
Dr. Sim, thank you so much for talking and for Dr. Weber to kind of ask all those awesome questions. I'm going to be starting a tumor practice in a place that has not had one. And I was wondering if you had any advice for someone who's starting from scratch and just kind of the outlook as you've had so many developments in your career. Is there any advice you could kind of give to someone who's starting fresh?
How exciting. That's very exciting and challenging. So I think you've got it all mapped out. This gives you the opportunity to select people. And when you get there, your radiologist has to be very, very good in helping you with these things and your pathologist. So pick your people, send them to your training center or mail takes to people. We'll give them extra training with some of our experts. So this really helps. And our former fellows do this when they get out. They pick the team, and their oncology practice, I'm sure, is still there if they're recruiting a top tumor surgeon. So I think the team approach is good, but how challenging, but exciting it is for you. I think that's going to be wonderful. Our fellows, when they first go out, I can remember a bunch that went to start new programs, and I got a lot of calls, which was fine. And that they knew how to do everything, but they just need a pat in the back. Say, yeah, that's good. That sounds great. That's what I would do. And pretty soon the calls get less and less, and I didn't hear from them anymore. So that's what it's going to be like for the first year.
Dr.
I
Holt,
still
you're ready.
call Frank. I still call Frank now. So it doesn't always lessen to 0.
Thank you.
I know we're running a little over time here, but if I could ask just one more question, and this really can go to any of the 3 of you, but Dr. Sim, in your experience, I don't know if you even have a preference for this, but when did you like to conceptualize your cases? You know, let's say there was a big pelvis or anything coming up. What was your go-to move as to run through in your mind, maybe plus or minus images, the case? Is it the night before, morning of, the week before? Like, do you have a routine as to how to approach these things?
Yeah, I think that's a very good question. And the answer is all of the above, basically. You think about a case coming up, and planning is the key. In the early days, we would take a procedure might not have been done or trying to make a variation. We get out of the lab and figure it out. But we would always have, in those early days, a skeleton on hand, and we would map out in the skeleton, draw on it, what we were going to do and make the steps. So I think planning is the key, like you said, and doing your review. When we would get these big teams together, I remember our first hemicorpectomy. I forget what year it was, but Mary was a resident then, actually, and we kind of had a computer list on the door there, a paper, telling each team what they were going to do and what time they were going to come in the OR and what to expect. So that was kind of the start of the big team, and it's planning and utilizing innovative techniques to enhance the outcome.
I'll just add to that, Paco. For me, when I see a patient in clinic that needs surgery, maybe they're going to get radiation before it's a soft tissue sarcoma that's maybe complicated, but I try to lock in then what I'm going to need. So I'm not last minute saying, oh, geez, I think I need a plastic surgeon and the case is tomorrow. So I sort of lock in my team actually really early. And then, if I'm going to need an allograft or maybe I'm going to need a different type of prosthetic or something, I try to think about that pretty early. And then I think about it again a week or 2 ahead of time to make sure everything is set. So the worst is when it's the night before and you're like, we're not going to be able to get that ready because that's going to take more than 24 hours. So, and then the anatomy, just going over the anatomy and the approaches. And, that's the thing about tumor surgery. You may be doing a foot case. You haven't done a foot case in, 3-4 weeks. It's not like you're doing foot cases every day. So you got to get the book out and remind yourself of all the layers and just make sure that anatomy is the most important thing you can do to understand.
I'm curious for Dr. Sim. I constantly, if I have a big case, as I'm going to bed through the night, as I'm waking up in the morning, that case is going through my head, steps and this and what's the hard part going to be. And I'm just constantly visualizing it. I wonder if that ever went away for you over the years and years and years that you operated. And I don't know that it's just my way of planning or doing. And I wonder if I will have to stop operating for that to stop happening. But I'm curious if that changed for you over time, if you were so locked in that you didn't, as the surgery was coming closer, think about it or, wake up thinking about it or that sort of thing.
I think it's a good thing. I don't look at that as a bad thing. Of course, I think that's very important to be having your mind. And I think your subconscious mind comes through with some pretty good solutions sometimes. You wake up and more, yeah, hey, this is what we'll do rather than that, a different approach or this or that. So I think it's really a good thing. You know, I got no surgeries now to plan, so I got to try to dream up something else to help me. So
You know, the nice thing, Ginger, is you organize this, and the MSTS is setting it up. But all these fellows, even though I don't see most of their faces, get to know each other probably partly through this program. So you get to know who's who, and it sets you up with a whole cadre of folks at the same level that have the same fears and challenges in their new practice. So it's a built-in support system. I love that.
Well, I want to thank Kristy, on par with Oprah for sure. Thank you so much. And Dr. Sim, this is an absolute treat for me. I know it was for the fellows, but an absolute icon. And a big part of us wanting to kind of put this stuff together is that I really want the fellows and every generation to know who you are and how amazing you are. And so thank you for inspiring us tonight and to continue to do so. I really appreciate your time and everything that I know you and Kristy kind of worked on everything. So thank you from all of us for the years and years and years, but for tonight especially is really a huge treat for me. So thank you both.
Thank you so much.
thank
Awesome.
you. Appreciate that.
Frank.
All
This
right,
is
everybody,
recorded,
take care.
This is recorded.
Yes.
Peter?
All right. Sounds good. Take care.